Welcome, everyone, and thank you for joining today's webinar, Remote Therapeutic Monitoring in 2026, from Technology Add-on to Core Strategy. I'm Marla Ranieri, Head of Clinical Innovation and Clinical Strategy at Prompt Health, and I'll be moderating today's conversation. We've brought together an incredible group of leaders who are not just talking about RTM, but actively implementing it, scaling it, and helping shape what it looks like inside real clinical environments and care models. And what makes this conversation particularly important right now is that RTM didn't just suddenly become more relevant because technology improved. It actually became more relevant because care delivery itself is changing. Clinicians are being increasingly expected to manage care longitudinally and not just during in-clinic visits, but between visits. And patients are becoming more accustomed to those digital touch points through all aspects of their life. I'm sure many of you have an Apple Watch or a Fitbit or an Oura Ring. There's just growing expectation to monitor progress, adjust plans in real time, ensure adherence outside of our four walls, and prove successful outcomes. So RTM does provide all those additional data capture and data points to help change your care model and to help do that. And this really aligns with a broader shift that's happening in physical therapy right now, where physical therapists are being positioned as first contact or primary care providers for MSK care. And with that shift comes a higher standard. So CMS has made it very clear, especially with the 2026 updates, that RTM is not intended to be a billing opportunity or a tech add-on. It's intended to support a fundamentally different care model. So that question is no longer, can we bill RTM? The real question is, do we have the right tools and knowledge to operationalize RTM in a way that improves patients' engagement, improves outcome, and creates sustainable care delivery models? And that's exactly what we'll unpack today. But before we introduce our panelists, just a couple of quick housekeeping notes. We want this to be really interactive, so you can see there is a chat. Please share your experience in the chat, say hello, tell us where you're from, and any reflections you have throughout this webinar. However, if you do have a question, we would ask you to put it in the Q&A button at the bottom of the screen. This way we can answer that question on demand, or at the end when we do Q&A, or of course afterwards if we don't get to it during this session. And with that, like I said, we want lots of engagement. So we're going to start with a poll. You'll see that pop up on your screen. And we want to know what best describes your current experience with RTM. So are you not using it yet? Are you exploring but haven't launched? Maybe doing a pilot, fully implementing it, or scaling across your organization? So let's let everyone take a second or two to answer that poll. Great. And hopefully we'll see some of the results on the screen after you answer that. All right. Perfect. All right, so we look like we've got a lot of people exploring it but haven't launched, and then and some not using it at all. Okay, great. And then with that, I'll have one more poll question for you. What's your biggest challenge with launching or scaling RTM? So again, you're going to see that pop up. Just maybe billing and reimbursement if you don't have the confidence there, or if you think it's too much of a work lift or burden, unsure which patients qualify, or really haven't found the right technology, or it just didn't stick. All of these different options, let you guys fill that out and then see where everybody lands with that question. And I love people dropping in the chat as well, so thank you for that. All right, so we'll close that poll and see those there. Okay, perfect. A lot on reimbursement and the staff lift. Okay, great. So whenever we run these polls, we kind of see a lot of the same, where people are sort of in the middle. They may be exploring it, or they haven't even tried it. And a lot of the gap is the awareness and the successful integration into your clinical model. And that's where a lot of the friction exists and what we're going to really be talking about today. So we've got a great list of panelists that will be able to dive in and be subject matter experts in this. First, we have Vikram Setharaman. Hi, Vikram. All right, Vikram is the vice. Oh, hey. Vikram is the vice president of product for Prompt Engage, which is formerly known as PT Wired. and he's been deeply involved in building patient engagement and RTM infrastructure that helps clinics prevent patient drop-off and operationalize RTM in scalable ways. Great to have you. All right, next we're joined by Brian Lang. Brian, say hi to everybody.
Hey, Marla. Hey, everybody.
And Brian Lang is the owner of Whole Body Health Physical Therapy, as well as the owner and director of strategy at Tandem RTM. Brian works directly with clinics across the country to launch and scale RTM programs with a focus on workflows that are sustainable and clinically aligned. And joining us from an operator perspective, we have Mary Rose Strickland. Hi, Mary.
Hello.
And Mary Rose is the president and co-owner of New Life Physical Therapy in Wisconsin. She's a board-certified orthopedic specialist, and she brings both clinical and executive leadership experience and has firsthand insight into what it takes to make RTM work inside a clinic. Great. So with all of these panelists and guests, we want to just start and set the stage at a high level. And Vikram, I'll throw this question to you first, but what is RTM really designed to do clinically, and what changes happened at CMS recently in 2026 that really signaled RTM is meant to be used and not just billed?
Yeah, so RTM stands for Remote Therapeutic Monitoring, and it refers to the set of CPT codes now that have been live for a couple years, which allow us to basically bill for the services that we're providing in between clinic visits to monitor patients, collect data on patients, and use that data and monitoring to ultimately make the best possible clinical decisions with their plan of care. So I'm going to go through the codes at kind of a high level here. This isn't going to be in the weeds of all the requirements or anything like that. This is going to be a high level overview of the codes and then also what's new. But we're also always happy, on a separate call if anybody really wants to get into the weeds and different interpretations or anything like that. But at a high level, these are the three codes that we call the patient usage-based codes. And the reason I refer to it that way is because part of the requirements for these codes are based on the patient's usage of the device or of the system which you're using for remote therapeutic monitoring. And that's kind of a key part of RTM is you need to have some type of a medical device. Most people use software as a medical device, which you're providing to the patient, which allows you to monitor that patient in between clinical visits and then collect the data that we need for RTM purposes. First code here, 98975, that's for the initial setup of getting that device to the patient or that system on the patient's device. That's billed once per plan of care, once per episode. That's about $21 there. The next code, 98985, is billed once every 30 days throughout the plan of care. And that's based on the data that we can collect from the patient's device. Data is, very, it depends what type of system or device that you're giving to the patient. But a lot of times this can be data like exercise completions, outcome ratings, activity trackers, different things like that can qualify as data transmissions that we're collecting through the device. And we need to collect 2 to 15 days of data transmission over a 30-day period to bill 98985. If we get more than 16 days of data transmission, then we can bill 98977. They're both paid the same at about $50. 98985 is a new code for 2026. Previously, we only had 98977, which meant that the threshold of activity that we needed to hit for a patient to be, or the threshold of data collection rather, that we needed to hit for a patient to be eligible to bill one of the data transmission codes was quite high. So now one of the exciting things for 2026 and beyond is that we have a new code which applies to lower levels of data collection, which is also paid the same. So these are the patient usage-based codes. The next set of codes are what I call the provider usage-based codes because it's based on the provider's time that they're spending monitoring the patient, updating their care plans, et cetera. First code is 98979. This is for the first 10 minutes of RTM treatment management services in a calendar month. And it includes one live interaction, which is one synchronous interaction with the patient, whether that's a phone call, FaceTime, a video call, or an interaction in person, as long as it doesn't overlap with other billable time in the clinic. And this is paid at about $26. This is a new code as well for 2026. Previously was just 98980 and 98981, so 20 minutes and beyond. So now we have a different code which applies again to a lower threshold there. For 98980, it's for the first 20 minutes, and you can't bill both 79 and 80. So it's not like you get paid for the first 10 minutes and then for the first 20. It's either 79 or 80, depending on the total number, the total amount of time during that calendar month. And then for 81, 98981, that's for additional 20 minutes of RTM time per calendar month. So if you hit 40 minutes, for example, you would bill 1 unit of 80 and 1 unit of 81, assuming again that you have that live interaction met as part of the requirement there. So I know that's kind of a very high level overview. Like I said, we're happy to go into the weeds if people need to on a separate call. We're more focused on strategy and implementation on this webinar. But as far as why these codes were introduced in new codes, the simple of it is that RTM works. We have a couple years now that RTM has been live. We'll get into this a bit later in terms of the actual data that has been collected in terms of how RTM impacts retention, outcomes, adherence. There's lots of data now because we have several years of RTM being out in the space. So if you haven't implemented RTM, which I saw in the polls, a lot of you have not, and if it's on your radar, now's the best time to start. One look at, this is for Prompt Health for our RTM claims submitted. If you look at the months here, for January, last month, we saw a huge spike in the number of RTM claims submitted, and it's because of these new codes, because now the thresholds are way easier to hit than they had been in the past. So RTM it's a better time than ever to implement it, as you can see by the numbers here. So if you're taking a look at implementing, now's the right time.
Oh, that was so great, Vikram. Thank you so much. It's great to hear all the changes and the positive changes that are being made. And Brian, I want to punt a question to you, since you are helping people implement RTM and also doing this in your own clinic. What do these changes mean if you're already doing RTM? So someone who's been doing it, what does these changes mean for them? And what impact will it have for someone who's just starting RTM in 2026?
Well, I think that Vikram hit the nail on the head a little bit with just these thresholds lowering. I think that's a big thing to consider first and foremost, because CMS really only has a couple ways to dictate how we move as an industry. It's the thresholds of the ability to actually generate the codes. So that threshold got lower. That should be an indicator. And it's based on reimbursement too. Medicare has the ability to decrease reimbursement. We've seen it with manual therapy, and that is kind of their indicator of how they want the industry to move. So in general, what I'm seeing here is that CMS is saying, we want you to use this. We want you to actually implement this because we're asking you to start doing more population health. And so it's like starting with the individuals who don't have RTM set up yet, that's okay. But consider this another message from CMS that this is something that we need to start considering. We need to start talking about. We need to start developing a plan. And then for those who have already started RTM, it's almost like it's an addition. It's just even a little bit easier to do what we were already doing because those thresholds being lower.
Yeah, icing on the cake, I'd say for sure. And we know that CMS and payers don't ever benefit us positively unless something really is working. They're normally decreasing our reimbursement and our codes. So this really means kudos to all of those who were the spearheaders of RTM, because the data is there and it is showing that it's driving outcomes, it's improving adherence, and that's why CMS has made these changes. So really, overall, it's great to see this, and it really should help you guys think a little bit more about how you're using this in your care models, not just adding it as a tool and a billing, because then, as we know, if you're just doing that, CMS may change these codes. So we do really want to talk about that part, how to make it as a care model. And the real question, of course, is what does this look like operationally inside a clinic, and how does your technology support that? So with that, Mary, I'll actually start with you. If you can ask me, what looks different day to day when RTM is truly part of care delivery instead of layered on top?
Yeah, absolutely. I think the key thing is it's the overall experience that's enhanced with RTM. This isn't just a here's how you access your home exercise videos that just leverages the technology, but rather you're going to get a phone call from somebody, and we build it as this is a person that's part of our team, part of the overall experience. We have enhanced communications. If there's early questions, if there's issues, we're able to catch those way earlier on, which helps our overall retention. It helps patients to, feel like they can be successful early on. So they come back for their follow-up visits. And truly, it just doesn't help with the plan of care, but it helps us stay connected with patients. And so with access being an issue, I think RTM is an opportunity to really connect, whether you're in a more rural environment, maybe staffing issues in your clinic, you don't have a lot of providers, but you can really enhance the way that you can communicate, connect with your patients, engage with them, not just over a plan of care, but hopefully over the course of their lifetime.
And would you say this really has created a hybrid care model for you in your clinic?
Absolutely. It opens the door to that. It allows patients to see how easy that can be. I think a lot of times, people do come potentially with different levels of comfort, and it's a low entry for a barrier to be able to see how this can work, and proof of concept of how we can use technology to stay in touch and work with people through a plan of care and beyond.
Great. And Vikram, can you walk us through the three most common RTM implementation models and how clinics use them today?
Yeah, so the three main ones, we call them full service, self-service, and then kind of a hybrid, which is a mixture of both of those. So the full service is basically some people call it white glove. It's basically where you work with a third-party company who staffs the providers, who then provide the RTM services, and in some cases assist with the billing for the RTM codes. This is kind of the least disruptive, I guess, for clinical workflows, because you're basically not having to block out provider time for the purposes of introducing RTM or actually providing the RTM services. The trade-off there is that you're often paying a fee. Well, you're always going to be paying a fee for that extra service that you're working with that third party with. And then the next one we call self-service, which is essentially each provider at that clinic manages RTM for their own patients. So it's kind of fully up to that provider to do all the RTM services provisions as well as the billing for all of their specific patients. And then the last one is kind of a hybrid between the two, where basically you still have a pinpoint RTM provider or providers, depending on the size of the clinic, who manage the RTM services provision as well as assist in the billing, but then they're internal. So they're still working with the patient, the clinical provider's patients. Each provider isn't having to do their own RTM. You have somebody else who's doing the RTM for that provider. However, that person is internal rather than external. The advantage there, of course, is that you retain all of the revenue. You're not paying a fee to a third-party company. Also, some people like the fact that it's a clinician from their brand, a clinician from their organization that's doing the care, regardless of if it's the clinician or the RTM provider. Of course, the trade-off is then you have the staffing costs of actually getting that provider, making sure they have enough volume to keep them busy, as well as the admin time and the whole admin of the implementation that they need to do to basically make RTM a success. Each one has its pros and cons. Each one can work well depending on how the clinic is structured as well as the goals of the clinic with RTM. We'll talk about each of these on the webinar today, but ultimately, lots of different people on this webinar will have a different answer of which strategy makes sense for them.
Great, great. And Brian, I know you are helping people do all these different types of strategies. So is there any kind of quick tip about maybe this strategy is best for starting off, or a large clinic or a small clinic? Any thoughts on that?
I think a lot of it has to do with when it comes to leadership, like what are your most important directions? Because when you start launching, let's start with just if you haven't launched RTM before, it's like trying to get the snowball rolling down the hill. There's a lot involved of like, okay, this is a different vertical that we need to implement in our company in terms of who is doing the the managing of this, who's actually doing the actual work, and then how are we making sure that we're hitting our metrics and getting this all built out correctly. None of that is anything that's foreign to us as clinic owners. It's more about, do we have the space to talk about, who is doing what, so we have this plan to roll out, and then finally going into how are we getting this messaging out and how are we educating our staff consistently. I think communication is probably the biggest driver of success on this. And if you haven't talked ad nauseum about different things about RTM, you're probably not doing it enough. So that's kind of like the biggest thing on there. What else? Sorry, I might have missed the overall question there, but that's what communication is the biggest thing. So I think that's probably the main thing I would talk to anybody interested in who wants to talk to me. I talk a little bit about what are your main initiatives, and that helps drive, like, is RTM right for you to do in-house or with a third party?
Great, perfect. And I know, Mary Rose, you had such a good point about it really needs to be a teammate and it needs to be embedded in all you do. So would love to talk about, okay, well, what is the real world implementation? How are you personally using it in your clinic right now? The model, how you landed there, and just overall how you're utilizing it.
Absolutely. So we're using the full service model. So we have a third party who is providing the labor for the provider to make the calls and to do all the monitoring. And what's really great about the program is from day one, we introduce and we brand that person as part of our team. And she's contacting our patients. If there's questions or concerns, she has access right through the prompt system. She can send us at tags. It's no different as if, she were just in one of our other clinic locations compared to where we're at. So from day one, they see her face, they understand she's going to be calling. They come back, oh yeah, I spoke with Laura and this is what she had to say. And this is, and by then we already know it. So like, yep, we talked to her too. And this is what's going on. So from that standpoint, it's really, I think, important to make sure that the patients understand that we're all part of the same team. We've got the same goals in that regard. And I think that's really important for the success of the program too. For us, the full service was the right choice just because we staffing is an issue. And so I wanted to keep my providers seeing patients and being able to generate, direct treatment one-on-one codes. So we're able to, leverage this and not have to put it off, because otherwise, if we were going to do it ourselves, we'd have to put it off. Also, something that just from a billing perspective, to be able to have the expertise on the billing and the reporting side of it, to look at, okay, now how are we doing? What changes can we make, and how can we make sure we leverage this, moving forward? We're seeing great value in that full service model.
Great. And a couple questions came from the audience of, are you using PTs or PTAs in that model? And are you doing it for all Medicare or all patients, just in general, what types of patients?
Yeah, so we have a PTA that works with us, who's been assigned with us, and Brian can speak more to that. At this point in time, we definitely do it with our Medicare patients, but there are a variety of other payers. So, we worked through a process with Brian and Vikram when we first started with this in regards to being able to test it and make sure that we're only, utilizing on the patients that we know we're going to get reimbursed. So through that process, we were able to find out, and now we have a list. So there's a list set up. All my providers know this is the list of payers we can use this with. Prompt makes it super easy to set that up with rules so that it automatically is recognizing this is the group or this is the person who's eligible, so that we can, go ahead and get that turned on and move forward with that process.
Great, thank you. And Brian, what about you? How are you utilizing RTM in your own clinic? Just the model, and how did you implement it and land there?
Yeah, so I mean, it may not be completely fair because I do this for other groups as well, but I would consider us one where we do it ourselves. And it made sense because I've been doing this for a very long time and I know the process around doing it. To the point of, what insurances do you start with? I consider any kind of rollout with RTM phased. So the first phase is you do it with insurances that cover the codes. And then you start in the second phase looking at other insurances and getting more information locally on or regionally on how they pay. And that's when you start to see kind of growth in the program itself. So for our company, it made complete sense to do it in-house because we had the team already kind of in place.
Great, perfect. And Vikram, there's a couple questions coming into the chat just about if the PTA needs to be in the same state, and if CODAs can do this as well. So if you can answer that for us.
Yeah, so first, lots of great questions, I see. Please make sure you put it in the Q&A versus the chat because it might get lost in the chat as we're going through things. But the PTA needs to be licensed in the state that the patient is in. So that's, or the provider in general. It has to be licensed in the state that the patient is in, who's providing the RTM services. Assistants can provide and bill for RTM. Some of the codes will need the CQ modifier if the assistant has contributed more than 10% of the requirements. So if you're thinking about the time-based codes, if they've done more than 1 minute out of the 10 or 2 minutes out of the 20, or if they did the initial setup, then you need to add the CQ modifier. If you're using Engage, that's tracked by the system. That'll automatically port over to prompt that if the modifier is needed there. And then the data transmission codes do not need the modifier. Those will never, the CQ modifier does not apply to the 7.7 or 8.5 codes.
Great.
And
great.
just specifically to CODA is included. So PTAs and CODAs, those are all fair game.
Perfect.
And sorry, one more thing about that too is that you do have to be like a similar discipline. So a PT doing the plan of care needs a PTA. An OT with the plan of care needs a CODA. You can't switch disciplines.
Perfect. Great. All right. Well, getting back into the implementation and some lessons learned, what would you say is the most common mistake clinics make early on? And Brian, Mary Rose, whoever wants to answer that.
I'll start. I really think that he's going to hear a very common theme, and it's the communication. It's really about getting the communication out, talking about what is true about RTM and what isn't, because in all honesty, it is brand new. And so it requires the leadership team to really say, okay, we understand you're going to have a lot of questions. We're going to get ahead of those questions to begin with, even before we go live. And we're going to have discussions about all of this. And then when it does go live, that doesn't mean that the communication stops. That means that we're going to continue to talk about things. And now we're going to start seeing some metrics. And now we're going to actually begin to use those metrics to talk about how this is influencing things. So oftentimes I talk about, 1 to 2 months is where everyone's still kind of feeling it out. Do I like it? I can't tell. 3 to 4 months, you start to have the providers have a little more understanding of the language that they use and when they use it. And then 5 to 6, we really should start seeing okay, this is becoming a lot more normalized. I'm starting to see the picture. I got some more ideas actually about how to make this better. And that's really exciting. But I think the biggest thing is communication.
Yeah, and I would say too, communicating the why to the
Yes.
patients and to your providers, because I think if your providers just see this as a billing addition, we're just going to bill more codes, they are not going to buy in either. They've got to really understand this is a better way to care for your patients. This is a better way to check in and, as you said earlier, population health, manage them, have more touch points and data to really provide the best outcomes you can do and keep them engaged. So love that. And would love to hear from your perspective as well, Mary Rose, anything that you wish you'd known before starting RTM that may have made it easier or help it stick sooner?
Yeah, absolutely. We actually had the experience of, we did start it a year prior to being on Engage with Prompt. And so we did have another experience and it didn't go great. And we learned a lot of lessons through that, which thankfully kind of made things be a lot more successful the second time around. And for us, one of our biggest issues was related to the billing and just understanding what that process was going to look like with patients and having the visits were going, all the codes were going out on a date of service where patients weren't seen. And so there was just some transparency issues and questions that came up. And so having a billing system that, number one, your clinic really understands how is this working, so then you can clearly communicate that to the patients. But the process that we work through with Prompt, they're added right to actual dates of service. So they're not something that's mismatched. So that was definitely something that's been much better at this point in time. And then really, like we've kind of touched on already with the providers, this is to help also make their jobs easier. As providers, we're being asked to do more and more and more in a shorter period of time, getting paid less and less to do so. And so this is just an opportunity to truly enhance and say, hey, our clinic, we used to love making phone calls after an eval to see how is a patient doing and how did they respond. And just with time and demands, we got to the point we could no longer do that. And so, just to frame it as this was an opportunity to do that again, and our patients love it and our providers can see, it's an opportunity to actually take some of the workload off of their direct, plate, but still be able to, offer that experience to the patient.
And I love that perspective that you did try it with a different system and so forth. And sometimes it's not necessarily the RTM that's not working, it's the process behind it or the seamless integration to be able to make it easy for your clinicians and your patients to engage. So for those of those who may have tried it and don't think it's successful, don't think that that's the end. Maybe there's an alternative solution to keep seeking out, because it does look like it's being very successful for many, many people. Well, you also mentioned friction, so want to talk a little bit about friction and common challenges. So Vikram, where do you feel that most clinics struggle when translating RTM policy into operations?
Yeah, so it definitely depends a little bit of which implementation strategy they pick of the three models, because each of the models, as we mentioned, have different pros and cons, which apply to the different struggles that may come up. For example, if you choose self-service, one of the struggles you may have is that you need to have every single provider educated on RTM, in the know about which payers you guys are billing for, about the billing, all that. And then, so that's one thing to consider, is that depending on the strategy and implementation model, you may have different struggles, but kind of across the board, we see people struggle with billing at the beginning, kind of going back to what Mary Rose briefly alluded to. There's different advantages, pros and cons of billing in certain ways for different payers. I wish there was a single billing strategy that I could cover on this call and say, hey, bill RTM codes like this and it'll be the best. Definitely not the case like that. That being said, one thing that we've been able to do is, since we have access to all the claims, RTM claims submitted for prompt, we have a lot of data that now we can help clinics with when we get onto calls with people, and then we can see which payers you guys primarily have, what RTM reimbursement data we can see for that payer for other clients. Doesn't necessarily guarantee that they'll treat you the same, but also how that's been submitted in the past, whether it's been submitted on the same data service, whether it's been submitted as a separate data service, the pros and cons of each of those. So that's, I know we'll touch on billing a little bit more later on this, but that's another struggle. But one of the more, the biggest problems that we actually see is provider buy-in sometimes. Getting the clinicians at the clinic to buy into to the idea of RTM, and then basically set up their patients on the system, on the app, or whatever you're using for RTM. So then, whether it's somebody internal, whether it's somebody external, to then give them a call, provide the RTM services, and ultimately bill them. That's kind of one of the biggest issues we've seen, is provider buy-in. So one of the follow-ups from this webinar, if you've registered, which everybody on this call obviously has, one of the things that we're going to be sending out in a couple of weeks is a one-pager, which is designed to be given to clinicians to basically kind of motivate them and get them to buy into RTM. As I mentioned earlier, there's lots of data now on RTM, how RTM impacts outcomes, retention, adherence. We did a study internally at Prompt, and we saw that patients who are RTM versus non-RTM, on average, and this is across several clinics, have 5.5 more attended visits per plan of care than non-RTM patients. So there's lots of other return on investment metrics that you can look at, which providers will certainly see value in, more than just how much RTM revenue are we making. And this one page that we'll be sending out is designed to basically address that pain point. But yeah, those are the main challenges which we've seen clinics face.
Great. And you mentioned provider buy-in. So Mary Rose, would love to know from your perspective, what's actually worked to address the provider buy-in issues that you may have done, and Brian, you can chime into as well.
Yeah, I think, again, just being able to allow them to see, the benefits to the patient and recognizing you don't have to be the one to sit there and, go through and troubleshoot all of the technology. That's part of the reason why we have the support of this other provider to reach out and ask how they're doing with it and, troubleshoot those problems in somebody who, again, through the full service, who understands that program way better than we do. So it allows us to kind of focus on what we know, allows them to focus on what they know. So, from that perspective, it's being able to say, we're going to use an electronic method for home programs regardless, but at least in this way, you have another partner in that care model who's going to help the patient feel successful with what they're doing, which ultimately is going to allow them to be more successful in adhering and hopefully then see better outcomes. So I think from that perspective, when they can see and understand that and recognize it's not them as the individual provider who's responsible for, troubleshooting and coaching and teaching the technology side, that's been, very helpful. And then the system making it easy to enroll. It's very, again, simple, straightforward. You can set up the rules, so it's not something they have to necessarily remember and go through these extra steps. It just kind of happens as part of that system, which is nice.
Go ahead,
Yeah,
Brian.
maybe to piggyback on that, I think that one of the fundamental pieces of this is if we look at ourselves honestly as an industry, people aren't doing their home exercise program the way we ask them to. Let's just be super transparent about that. And I think that a lot of times I'll ask providers if they've been to physical therapy before. And if you look at your entire plan of care, out of 100%, how compliant were you with your home exercise program? And we always have people who are like, okay, they were great, but most people put themselves probably around like a 70 or 60%, maybe 50. And then, I'm looking at them and saying, well, we are as physical therapists, like we know the value of PT, right? We believe in it. We should be the best patients. And we're still getting C's, D's, and F's. So what are our patients really doing? And that's not a problem with, I think that's a problem of the system because we get paid by our visits, not what happens in between until now. So now we have this opportunity to pierce this veil of what the heck is happening between when the patient leaves our four walls and when they come back, right? And that's huge and impactful because if we as PTs truly believe that our plan of care is more important in terms of what is happening between there, then this should be a perfect alignment, RTM and how we treat.
So well said. I mean, I think that just drop the mic on that. It really is the way it's changing to is being able to be a coach and not just check in on home exercise program, but health and wellness. That RTM provider can be checking in a lot of different metrics, gait and nutrition and sleep, and all of that is really where this is headed. So I think it's a great starting off point for how we're managing them on a long scale. And Vikram, you mentioned a little bit about interactions, like live interactions being a bit of a challenge and a problem. So any thoughts, Mary Rose or Vikram, on how to make sure you get those live interactions and you're able to mitigate those challenges?
Yeah, so there can definitely be a challenge if one of the ways you're getting live interactions is calling patients at unscheduled times throughout the calendar month. I saw somebody put a question in the Q&A about this as well. By the way, we have a ton of questions. There's no way we're going to answer them, but I will promise I will email every single person with an answer to your question. So keep them coming. If I know we already have over 50 in the Q&A and a lot in the chat, but keep them coming. We'll get back to everybody. One thing that was clarified in the final rule of last year was whether in-person time can count as a live interaction. It was more kind of explicitly said that it can count as long as it doesn't conflict with billable time, which means if you're billing, for example, therapeutic exercise for that block, and then while you're doing that, you're explaining the system or the app or whatever to the patient, you can't count that as a live interaction. So what some groups do that we work with is at the end of their eval or at the end of a visit, they'll leave some time, some minutes open and from a billable time perspective. And then during that time, they'll explain the app, they'll explain RTM, they'll explain the features of whatever device they're providing to the patient. And then that can count as a live interaction for that specific calendar month. This is obviously something that you'll do on the self-service model. You're not going to do this if you're working with a full service company or if you have a pinpoint RTM provider. you know, it's more likely that you'll do it on that self-service model. So that's one strategy. But one of the good things about working with those full service companies is, you know, that's what they do is their whole thing is finding time to get the patients on the phone, getting that live interaction done, getting all 10, 20, or 40 minutes of monitoring time done during the calendar month so that you don't need to change how you guys do things in the clinic to get that live interaction completed.
Great. Great. And altering that live interaction. Don't always call them on a Monday at 2 p.m. the exact same time, you know, making sure you're actually alternating those times that you're doing that, I think is really beneficial too. And that brings up a big question. I know tons in the chat about it, just overall common mistakes with payers, insurance, and billing questions. And Brian, I'll let you start on that one.
Yeah, I think that the biggest thing would be, because the question is, how do you handle patient responsibilities, right? Like that's a big fundamental one. And it becomes more of a question as you move into commercial payers, because plans are different at the plan level for commercial payers. The biggest thing I'll say is that the best thing you can do is own it. Own RTM. We do it. We charge for it. This is what can be expected. We consider it a value. We consider it the same value that it would be if you had a copay for an in-treatment physical therapy visit. The data is showing it that outcomes are better. We model our care so that we can help with our visit, you know, utilization because we have RTM implemented. You continue to show that value to the patient too. And then when you have that full transparency, that's a huge part of that journey, because you just explained it, and now we're a little bit again more aligned. Going from the billing end, I think that there is a lot to unpack with different billers or different companies and how you should bill them in order to get paid appropriately. There are nuances in terms of denial management. All of them are fixable, but that's why we typically do this in stages, because you don't always know what you're getting yourself into until you start doing a few tests, getting permission, billing a few out, and seeing how some of those regional payers are paying them, and then making decisions on what you're going to do from there.
And Callie mentioned something really great in the chat about how if you do this RTM right and you explain it right, they might not have to come in for as many visits. And believe it or not, I know sometimes that sounds crazy to people who only measure length of stay and overall how many visits you've had in total. But if you can get them better, faster, in less visits, that's more time for them to have at home. And it also is more time for you to see a new eval, which is really valuable, getting access a new patient in the door. And evals are reimbursed at a greater rate too. So we're doing a service by everybody, being able to create that plan of care in a more efficient manner and check in with them, as well as opening the door for more evals. So I think that's really valuable.
That is also, I think, a good thing to discuss for high deductible plans. You know, I actually think that RTM is probably a great thing for those. If the therapist says, you know, normally I would see you twice a week for 4 weeks on here, but if we include the remote care navigator in here, the biggest thing is that we're really consistent with the program. And if they're part of it, we can probably drop this down to once a week. We can kind of, I'm hearing you about the expenses, but we can actually help accommodate that. It's a good message.
Yeah. And I know lots of people want to know about results. So what actually is the financial impact you have seen from RTM? And Mary Rose, I'll start with you.
Sure. So for us with the full service model, it's easy to evaluate. We look at what's the percentage we're paying for the full service versus what's the percentage that we expect to then bring in our collections. And I can tell you, we are seeing a complete return on our investment with this. So it's made it, part of the reason I'm here today. It's part of the reason I'm very excited and passionate about where this is going. Is not only is it enhancing our practice and allowing for better care, allowing for us to stay connected with our patients and move into the new strategy of where our private practice is going, but it's doing so in a way that we are seeing the return on investment. And as a practice owner, it's not sucking up all my time. I mean, that's a big thing too, is, there's opportunity and time cost to these different programs that you implement. And again, for us why the full service was definitely worth it. But we are seeing the full return that I was told we would. We are seeing it, which is excellent.
And can anyone give us some numbers in terms of increased adherence or plan of care completion or any of those metrics from a quality or a quantitative perspective?
Yeah, so the one I mentioned from the internal study that we did was 5.5 average visits per plan of care increased for RTM versus non-RTM patients. And that's not just that some people who would have dropped off with that increased engagement are ending up completing their plans of care, but also those additional check-ins that remote provider is doing in between visits. Sometimes we'll just remind the patient they have a visit the next day, and then they don't miss their visit, and then that can be the difference as well. So there's lots of advantages to those extra touch points. Some other studies from from the industry, from the space on adherence, 15 to 40% increase for RTM patients versus non-RTM patients, and 57% improvement in adherence from another study, which is more tailored around measuring drop-off. So there's lots of stats on this. Like I said, we're going to be sending out that one pager that has a breakdown of all the studies to motivate anybody to see the light, see the value in RTM more than just the dollars that come in from the CPT codes being billed.
And Brian, what about you? Any subjective or objective results that you've seen in your clinic or in other clinics that you've been managing?
I think one of the things that everything was, I agree with all those that were already mentioned. I think one thing I wasn't expecting was home exercise programs that, as owners, like we don't have time to look and see is every single patient getting a home exercise program or not. Like we don't have that micromanagement ability. But for the remote care navigating world, like we have to have the patient have access to the FDA compliant app, and they have to have a home exercise program to do that. So what I've kind of seen is that there are a lot of people who don't get a home exercise program. And on top of that, if they do, we can also see when that was last updated. And if it's been 6 weeks since anything has been updated, no additional sets, nothing, what that actually ends up doing subtly is like driving us up a little bit in terms of what we're providing as a value, which is just exciting to me again, because that makes our in-clinic experience even better too.
Absolutely. That is spot on. And I think that's a really great value add to understand, because I don't want to say PTs don't have time to do that, but this prioritizes the time to do that. And then your remote therapeutic monitoring can check in and make sure that those exercises have been updated. Because a lot of times, again, that does get forgotten. And if we value our plan of cares and we do want them to be doing that at home, we have to make sure they're communicating and seeing that same plan that we provided to them, especially with those Medicare patients. And with that, I'd also, Mary Rose, if you have some input onto why you feel that the actual tool and technology that you utilize provides good results in general. So the difference of a tool that may not be fully integrated in your system, your billing, your processes, and one that is, and how that makes a big impact from you seeing both of those tools being done in your own clinic.
Yeah, absolutely. Again, I think it's compliance. It's compliance on the side of your providers. When you have a tool that it's one click in your documentation and you're able to, get right into the screen, that all of the patient information is already added. So when you go from prompt to the Engage platform, you're not having to re-enter that patient. Everything's just right there. So very, very easy to get over there. It's very easy to copy what you're doing and then put it right back into prompt so that those systems can always be up to date and working together. And then on the billing end, it's a similar thing. So prompt has backend rules that it can, hold a certain, and this is again, just how we're doing it. I know Vikram mentioned there's so many different ways and it might be different for other people, but through the ability to create these backend rules and have these systems, it's been just completely seamless for us. So that's been the huge advantage of having a tool that's, well integrated and communicates, well, is you're not spending your time as a provider or as a biller trying to make this all go. You can just leverage what's already there and then spend time, like Brian had said, actually updating your program, actually making sure your patient is engaged with it, and prioritize more important things.
And I'd take one step further and say if your providers aren't writing tons of notes at home, so you have an EMR or scribing tool that allows them to get that done quick and fast, then they can focus on these extra pieces like the home exercise program, the RTM, allow that time and space, and even allow time for a new eval, like we said, to really manage at a higher level. So really great feedback. And we have a ton of questions, so I want to make sure I leave a lot of time for that. Let me see. We've got a few, and with this we did touch on a little bit. Just want to explicitly say, does RTM increase the patient's out-of-pocket expenses?
I would, this goes back to it depends. And when it comes back to it depends, it means say that it will and own that it will and that it's a value. I know that sounds too simple, but it really will help address the whole thing as it gets more and more complex with different insurances and how they pay.
Great answer.
And to add to that with your providers, if you tell them this is part of what we do, it's not an option. It's not an option for my providers to say, I want to do manual therapy, but I don't want to do therapeutic exercise. Like, we don't talk through those options with the patient. So like Brian said, this is what we do and this is how we can provide value. And this is just a part of it. And you package it that way.
Great. And then we have a question asking, what about pediatric outpatient settings? Is there anything different for this type of a clinic?
That's a really good question. There is some nuances with that. It's not utilized very often in my experience so far, in terms of not that it's necessarily a problem. I just haven't seen it happen very often. Some of that probably has to do with the payers who are paying, because Medicare started this, and you can have individuals who are on Medicare, but oftentimes it's another insurance. There's just a few more nuances that you have to go into to understand, like are they covering RTM codes in the first place, and how do they cover them? But in essence, if they are covering RTM codes as an allowed amount, then the whole rules stay the same. The parent would be the one who would be depending on the child's age, but the one who's communicating and making sure that the program is being completed between visits, but it still could happen.
Great, thank you. And this is a great one from Rick Douglas asking, he is evaluating RTM and considering scaling it, but he wants to know how others are tracking costs, including opportunity costs, in general, tracking revenue per unique patient and revenue per unique eligible patient, but having a difficult time tracking opportunity costs. Any suggestions there?
Yeah, I mean, obviously, we alluded to a couple times that other stats, the other metrics which benefit a clinic, in addition to just the raw revenue number that you have for RTM. That's of course not to say anything about the subjective side. Maybe Mary Rose or Brian can speak to a little bit more about the patient experiences and kind of feedback from them on having that extra layer of support, having those extra check-ins. But plan of care length for RTM versus non-RTM patient, drop-off rate for RTM versus non-RTM patient. Those are some other stats to look at when you're kind of evaluating ROI for implementing RTM.
Yeah, I love that. Plan of care completion, absolutely. Self-DC, are they discharging themselves? Or are they actually being discharged by the PT in their plan of care? Great. Well, this one from Michael is about a patient going out of town for 2 months. Can we keep up with RTM and bill that without a physical visit? So there's actually two questions to this, because one is that he's out of town and the other is to keep up with RTM.
Yeah, so yes, you can. As far as billing as a whole, I'll kind of touch on this for a second. I've seen a couple questions on, do we bill this as part of an actual visit? Do we create like a separate RTM visit to bill this? In Brian's words, it depends. And part of what we want to do is we want to be a resource on this, because it is very tricky, especially like when you're getting commercial payers involved, to bill RTM. To give some examples, you may have a plan where you have a flat 4-unit cap on per visit. And then people will often think, okay, I can't attach my RTM codes to that because they're not going to get paid, because that will be more than 4 units. But then we're seeing RTM codes for plans like that getting paid on top of the 4 units, because those are monitoring services and not therapy services. So there's a lot of nuance here. We have access to a lot of data on different claims submitted and for different payers, and we can be a resource. We can be a guide for this. Ultimately, at the end of the day, you're going to need to try billing the codes or contacting the payers to really see for the commercial side, how this is, what your specific situation will be. But to circle this all the way back to the actual question, in this case, obviously you would need to create a RTM visit to submit those codes because that patient wouldn't have come in that month. So you would need to basically create an RTM visit to attach the codes in that case.
So yes, that way. And then you do need to make sure you're licensed in the state that they are traveling to.
Correct. Yeah, exactly.
Great. And then how are you addressing patient responsibility for RTM? Are you having info in the intake paperwork addressing during discussions, or just telling all about RTM is? How are you explaining that to the patient?
I know Brian will take this one.
Just all the above. I mean, it is all the above. You do it in the intake. You talk about the value and why you're doing it. You talk about the patient responsibility that they could see something, and this is kind of what the range can be. You just get really ahead of it, and you say it again and again.
Perfect. Perfect. We say you need 7 touch points for somebody to actually hear you. So that's accurate. We're going to keep answering questions, but I want to put up a quick poll as before, so making sure nobody leaves yet. If you do want to learn more and you want to learn more about Prompt and the EMR, if you want to learn about Prompt Engage, which is also formerly known as PT Wired, or you want to learn more about Brian, his clinic, and Tandem RTM, or Mary Rose and New Life PT, please feel free to indicate that so that we can make sure to give you the correct services and follow up with you afterwards. All right, great. So as that up, I'm going to keep answering these questions. This is a one about the new codes. Is it correct that the updating of exercises, reading the patient's feedback, and monitoring the patient's performance would fall under the 98985 and 98977 codes?
No, so I think that was a bit of a mixture of the different requirements. So the different activities that were listed there are the time-based activities that would count towards 79, 80, and 81. For 98985 and 98977, those are based on the data transmission readings. So that's based on the patient's activity on the device and the device's collection of data.
Great. And that one slide that you sent out that you showed earlier, we will put in our email follow-ups as well, right?
Yeah, absolutely.
Do you have resources for full service companies? Not sure.
Yeah, well, we have one on the call, which is Tandem RTM, Brian Lang here. That's if you're a Prompt group, that's the one that we are currently working with. So yeah, I'm not sure if can they see Brian's contact on here? Or maybe it could be that you could put it in the chat.
Right. If
Or I
they
guess if they did in a poll too.
Yeah, if they click interest in Brian, then Brian will absolutely follow up.
Perfect.
Great. Then this one, is it just Medicare or Medicaid? Do they do it as well? For RTM.
I'll hit it. I'll hit on this. Depends. It depends on the who is the insurance that is supplying the coverage for Medicaid in the region. There are blanket statements that are just no, and then there's other insurances where they actually are covering it, though there are some nuances to that just in terms of we like to look at what are they paying, like how much are they paying? Is this still a value for us from a financial perspective? But I hate the answer, it depends, but there's a lot of it depends based on the region that you're working from and who the payer is.
Great, thank you. And then I'm going to take this one. Is anyone implementing a cash-based service or model with RTM?
I'm not doing this yet for cash pay, but we're definitely exploring it as we're looking at, what potential membership models look like, being able to have like asynchronous communications and way of continuously staying in touch with patients is huge. And that's exactly what this is setting us up for. So we're not there yet, but we're definitely exploring it.
I've seen some already. We're also exploring it too. it seems like a nice, easy road into cash pay practices, even in the sense of RTM happens when a patient has a plan of care, right? When a patient's discharged, now all of a sudden we have to conclude RTM. And if the discussion is like, hey, if you want to keep going with having somebody check in with you just to kind of keep everything going the way we had this planned, we do offer this as a cash pay service. It's this amount. You can take it if you want to. It's a really, really gentle way to do it.
Great, great. And as we said, we have a lot more questions. We will follow up with all of them after this call. So thank you so much. But really, if there's one takeaway from today's conversation, it's that RTM is not just a billing strategy, it's a care delivery strategy. And the clinics that succeed with RTM are not the ones that are just implementing as a technology and an add-on. They're the ones intentionally redesigning workflows, aligning their teams, and embedding RTM into their existing systems and how they deliver care. And as healthcare shift happens towards more longitudinal outcomes-driven models, RTM will be a foundational component of modern practice and not an optional one. I truly believe that, and hopefully you've heard that from Brian and you've heard that from Mary Rose. And really want to thank all of our panelists today. Your information is invaluable, and your time to be here to help everybody. We appreciate it, and we thank you for joining us. And as I said, we will share all the resources and follow-up materials after this webinar. And we hope this conversation has really helped you think differently about RTM and can help you enable it inside your organization. And we're here for you in case you need us. So thank you so much. Appreciate you all jumping on today. Till next time.